All right, good morning, good afternoon, good evening, everyone. Thank you for joining our Q&A session to enhance your understanding and use of provider behavior change tools. A few quick logistics. Please go ahead and choose your language as we do have a live interpretation. So if you go to the interpretation icon at the bottom of your screen, please select your English or French. So a quick overview of our session today. I'll be providing a brief introduction of the provider behavior change or PBC tools. We'll also introduce our panelists and hear firsthand from their experiences adapting and implementing the tools. And we'll also provide an opportunity to ask questions of the panelists to inform how you might be able to apply the tools in your setting. So we will be utilizing the meeting chat as well as the Q&A button at the bottom of your screens. Please feel free to type questions into the Q&A session or icon at the in the Zoom platform and use the meeting chat to give comments and provide insights on your own experiences. So a quick overview of the tools. So our first tool in the provider behavior change set of tools, we have our provider behavior ecosystem map. So this is a thinking tool. The map shows how many factors at different levels shape providers' behaviors, and it highlights the value of considering the whole system and exploring and identifying the relevant influencing factors to that behavior. So this map really is used as the starting point in terms of creating and improving initiatives that are aimed at provider behavior change. This map is available online and it's a very interactive platform, so you'll be able to see all the interconnectedness between the different influencing factors as well as key definitions and terms. And if you scan the QR code at the top on the screen, it will bring you to a link to view the ecosystem. And we can also drop in the chat the link that we have at the top of the screen. The second tool that we'd like to highlight is the PBC Toolkit for Family Planning. This toolkit is used to further understand and prioritize the factors that influence providers' behavior. So it can help SBC and service delivery actors design local initiatives that are appropriate for their context that tackle the root cause of a behavior. So this toolkit, while this one is specifically focused on family planning, you are able to adapt it to different health initiatives or health areas. And it helps users walk through a 4-step process that includes prepare, where we have the users identify the focus behaviors in the facilities and really lay the groundwork for data collection and ideation. In step 2, inquire, the users of this toolkit will then collect data on provider behavior influences across several different levels of the ecosystem. And there's multiple different tools that you can use within this toolkit. You don't have to use all of them, but they're each adaptable to your context. Step number 3 is synthesize. So making sense of the data and identifying the priority areas to target and your program design. Again, there's a couple different tools for this, including a daily synthesis sheet, as well as a global synthesis sheet to really summarize all the information that you gather in that inquire stage. And then lastly, act. So this is where users will then generate the solutions for supporting provider behavior based on the needs that were identified in that inquire and synthesize steps. The toolkit overall is a very collaborative process. So you identify all the different stakeholders that need to be involved. You create a core implementation team with representation from each area that you find crucial to identify behaviors and also make that proper impact. And you're also working alongside the providers the whole time. So they are involved in every step along the way. And again, if you scan the QR code on the screen, you can view the toolkit online, and we can also drop the link in the chat. And the last tool that we'll be discussing and sharing with you today is approaching provider behavior change, monitoring and evaluation with a socio-ecological lens brief. So this brief helps to explore the new frontiers of applying a a social and ecological lens to the monitoring and evaluation and many of PBC interventions. So it uses organizing structures of the provider behavior change ecosystem map, the tool that we mentioned earlier, to discuss insights, findings, and recommendations. And within this brief, there's also a list of illustrative indicators that can be considered for use. The primary audience for this brief is program planners and implementers that are working at the intersection of health system strengthening, also in service delivery, as well as social behavior change, or otherwise working to understand behavior change and improve provider behavior through PBC interventions. And again, this brief is available online, so you can scan that QR code on the screen, or we will also drop that link in the chat. We have also included links to tutorial videos on each of these tools in the meeting invite. Each of these videos are available on YouTube, and we can share those in the chat and also in another follow-up email after this Q&A session. But those YouTube videos are very helpful in providing step-by-step examples of how to implement each of these tools. And now we'll move on to meeting the panelists. So I'm Allison Pack. Apologies for not introducing myself sooner, but I am the program officer at Johns Hopkins Center for Communications Programs, and I will be the moderator for today's session. So I was also a part of the team that helped to create these tools. So I'm happy to answer any questions about the backend in terms of the development of these tools. And I also work on Breakthrough Actions, SRH, Sexual Reproductive Health Core Team. We next have Danette Wilkins, and they have over 15 years of experience designing and implementing global research, programming, and training in Africa, Eastern Europe, Latin America, and the Caribbean, North America, and Asia. They are a program officer at Johns Hopkins Center Communication Programs as well, and they've worked in a wide range of health and development areas, including agriculture and economic growth, democracy and governance, education, environmental and natural resources, health, and gender. They're focusing on applying social behavior change approaches to SRH programming aimed at healthcare provider, men and boys, and sexual and gender minority youth. They also contribute to gender mainstreaming and integration across global offices and projects. Next, we have Barbara Nabar. She is a senior technical advisor for SBC at FHI 360. And she's currently working at the USAID Uganda, currently working on the USAID Uganda health activity. Before this role, she worked at Pathfinder International Uganda as an SBC manager for the USAID Uganda family planning activity. And her career is driven by a passion for improving health outcomes through strategic behavior change initiatives. And lastly, we have Kenny. Kenny is a social and behavior change and gender advisor for the Momentum Integrated Health Resilience activity in South Sudan. He is the former senior technical advisor for SBC for Breakthrough Action South Sudan as well. So we now will move on to our question and answer session. Let me go ahead and stop sharing my screen so we can see all of our participants here. Excellent. Okay, so as I mentioned earlier, please feel free to drop any questions you have for our panelists in the chat, but I'd like to go ahead and kick things off by asking the panelists to share about how they ended up using the tools within this toolkit. And perhaps we can also go into a little bit of why. Barbara, would you like to kick us off? Oh, I think you're still muted.
Sorry, yes, I was muted. Sorry about that. So good morning. Good afternoon and good evening. Yes, so I need to mention before I proceed that I've interfaced with the PBC tools at two different projects with two different organizations. I started with the PBC with USAID Uganda Family Planning Activity at Pathfinder. And shortly after we had rolled it out, I crossed over to FHI, where I found that they had also started working on using the tools. But why we decided to use the tool at the time was because we are looking for a comprehensive and more structured approach to be in position to deal with provider behaviors, because at the time we rolled it out at family planning activity, we had quite a lot of should I say, issues or problems with provider behaviors, especially to family planning uptake. We had done a lot of a root cause analysis to try and understand why the uptake of family planning was very low in the country. And most of the responses or most of the causes kept on pointing to provide a behavior. And I think that's the time when the PBC tools were launched. So we decided to take them up, to be in position to, like I said, get a comprehensive and structured approach of dealing with provider-related issues to service delivery. And also the fact that we're in position to understand the different barriers and facilitators to behavior, which were highlighted in the toolkit, I think to us that was the reason why we mainly looked out for the PBC and tried to start using the tools. Thank you, and over to you, Camila. Yeah.
Thank you, Barbara. And Kenny, would you mind sharing with us a little bit more about how and why you've used these tools?
Okay, thank you very much. I am Kenya Athanasius. Prior to this, let me say, the implementation of the Provider Behavior Change Toolkit, I was working with the Johns Hopkins University Center for Communication, and that is the Breakthrough Action South Sudan. And in South Sudan, we also piloted the implementation, let me say, the PBC toolkit at its third fidelity, where we tested it in 3 locations, and that is Juba, Yambio, and also in Wow. And currently that we are implementing the provider behavior change toolkit, we initiated, we thought of using this because our Momentum Integrated Health Resilience initially conducted a social norms assessment in the country. And through the social norm assessment, we were able to learn that the location where we are currently implementing this social, let me say, the provider behavior change toolkit, we realized that it's one of the locations in South Sudan with the strongest social cultural norms. Also coupled with the fact that through our service data, we are able to realize that the slow uptake of family planning services at public facilities compared to private facilities, which in fact are charging small fees for delivery of family planning services. So we decided to use this PBC toolkit to be able to understand what are those influencing factors. Apart from what we've already known, for example, the strong social cultural norms in these locations, and also wanted to know if the providers who are providing family planning services in these facilities are also moving with the socio-cultural norms from the community into the facilities. Yeah, thank you, and over to you.
Thank you, Kenny. And Danette, now hearing these reasons why Kenny and Barbara both utilize these tools, do those align with the reasons why the tools were created in the first place?
Thanks so much, Allison. And so wonderful to hear about the experiences that Kenny and Barbara have been having with these tools. And it does absolutely align. There's been a trend in provider behavior change as far as where our focus has been over the last several years. Initially, there was a lot of focus that was very individual, so focused on the provider, but not actually looking at the provider as a person, more looking at the provider as a barrier to health outcomes. And so wanting to shift that focus to viewing the provider as a person, understanding the universe in which they operate and all the different factors really helped to expand the provider behavior change field to move beyond that narrow individual lens, the interpersonal lens that's focused on provider and client facility, to really be looking more at the larger context in which they're operating, understanding how the health system is tied to the national government and laws, and how all of those structures, those policies that are in place, then make it possible to determine what is going to be the outcomes for different health facilities, their resourcing, their staffing, and all these things that we know end up impacting providers on the ground. So I really appreciate what Kenny shared as far as doing this situational assessment, because social and cultural norms are such a huge factor when looking at providers as individual people and understanding how their own attitudes, beliefs, and values factor into their service delivery. And I'll stop there because I'm just really excited to hear more from Barbara and Kenny about their use of these tools.
Thank you, Danette. So especially with the mention of social norms and cultural norms within groups, I'm sure Kenny and Barbara, you ran into some challenges when implementing these tools. Could you share with us some of those challenges?
Okay, thank you very much. When we initiated the rolling out the provider behavior change toolkit in one of the facilities, it became clear to us that our providers were so hesitant to share information with us. Of course, they felt like the toolkit is trying to investigate them, and some of them were holding back information, and they are not like releasing information quickly until when we reach almost towards the end, when they learned like it will help them or create a situation where they can be supported. That's when some of them started opening, but otherwise they were holding back, feeling like, oh, these people are trying to investigate us. So this is one of the key challenges I faced during the implementation. And of course, in some of these locations where we are implementing this provider behavior change toolkit, we were also able to note that the in-charges were feeling like we are looking for their replacement, possibly because of the questions the provider behavior change is trying to dig into. What in fact influences provider behaviors in the facilities where they are leading. Over to you.
Thank you. Yes, building trust with the providers and the in-charge is crucial in this process, because it is so collaborative to make sure that we aren't putting any sort of blame on the providers themselves, that we really want them to be engaged with this whole process as well.
Yeah.
And Barbara, how about you? Any challenges?
Yes, more or less what Kenny talked about, because back home in Uganda, we have, I think we are a society that is deeply entrenched in the social cultural norms. So at first it was really, really hard for the providers to break through, to be in position to open up and give us the correct answers. And I think at the start, they were trying to avoid giving us responses that concern them as providers, and trying to probably, I don't want to say shift the blame to the broader health systems issues, for example, the workplace environment, for example, the financing and all that kind of stuff. But the main challenge that we found at the start was that kind of resistance that my brother also hinted about. But as we kept on, interacting with them, reassuring them that we are trying to identify some of the barriers to the uptake of some of the promoted behaviors, with time, they kept on loosening up and were in position to run the tools as expected. Yeah.
Absolutely. Thank you. And With that said, before I open the floor for other questions from our guest here, what recommendations would you have for others interested in using or adapting these tools?
I think one of the recommendations that I could give to the rest of the people who would wish to implement these tools, probably I could highlight another challenge that we face apart from the social culture and gender and values issue was the nature of the tools themselves. They're such a comprehensive in nature to the extent that I think we did not utilize all the tools. They're too heavy. They take a lot of time. And I remember we are administering them at the facility setting. So that means that the health workers have to spend some reasonable amount of time off the work. So it was one of the challenges that we faced. So for the people who would love to take on the PBC toolkit, I think if we could come up with an edited version, which is not as comprehensive as this, maybe an obliged version, it will be easier for them to administer the tool. And then also the fact that it was comprehensive in nature, and also, for example, at my first project, since we did not have like a separate team to implement the tools because we tried to leverage on the ongoing programs, we did not have, I should say that the people taking up these tools should invest so much in training the team that is going to run the tools. And this stems from the fact that the tools are so comprehensive. So for people to implement them to fidelity, they need to know, go through all the tools, know how they work, how they relate with each other, for them to be in position to get the best out of the tools. Yes.
Absolutely. Thank you, Barbara. And Danette, I saw you nodding your head a lot. Would you like to speak to a little bit more about how these tools are so adaptable and kind of some of the suggestions Barbara mentioned?
Yes, I really want to uplift what Barbara said. It's so important to get familiar with these tools, to even have some training with the teams. And so thinking about how you want to work that into your timeline for the project. And also recognizing that that training opportunity with the different partners and stakeholders around the tool is also part of capacity building and strengthening, right? So that's a way that you can advocate for the time to be able to do that work with the donor. And again, to Barbara's point, you all know best your project resources and timelines and what's possible. And so feel free to make the adaptations that are necessary. And also it might be important to think about, what are the things that you really shouldn't cut, right? Sometimes we do need to take shortcuts, but there are some shortcuts that could actually take away from that process and those significant pieces. So I would actually be curious to hear from Kenny and Barbara about, if they made any shortcuts, like what those shortcuts were and what were things that they really recognized as being critical and needing to be done thoughtfully and intentionally with the team.
Okay, let me jump in first and then Barbara will follow. Yeah, I think in terms of the recommendations, I think Barbara touched most of the recommendations I have. For example, as she mentioned, we need really to, first of all, give more time in training of the core implementation team. For example, at least 1 week is enough to train them to fully understand this. Learning from the experience I had, I think I had a very good, let me say, time frame for training the core implementation team, and they were of a greater support during the recent implementation I had in BOR. And then the other thing that I also wanted to share in terms of the recommendation is that we really need to make sure we adapt it to the context. For example, the provider behavior change toolkit that we are currently using in South Sudan is adapted to the fragile settings or the context of our country, where we have the influencing factor cards are adapted to what is happening here in the country. So anyone who would want to use this toolkit should also look into that and make sure they understand their context and are able to adapt this tool to their context, or have the influencing factor cards reflect the context of their country, as well as also the other cards. For example, when we talk about the inspiration cards, we also need to make sure you look into that and make sure you adapt it to your country. And then the other thing that I also wanted to say, to mention, is that for people who wanted to adapt this tool, when you are almost reaching the middle of the tool, for example, during the diagnosis process, sometimes things tend to come like, okay, messy, or sometimes you tend to get confused, but it's okay. It's always good to feel that way, but then it gives you that opportunity to start thinking outside the box. How do I move forward from here? And that situation, I think, is a normal situation that anyone who intends to adopt this tool should be able to put into his or her mind that at a certain point during the implementation, there is going to be the situation where I will be very confused, but it gives you an opportunity to think. And then in relation to Danette's question, I think, sorry, would you help remind me of the question?
I'm happy to, and Kenny, I appreciate so much what you said, that confusion is generative. It really is, right? When we're confused, it means maybe think outside the box or think differently or gather other perspectives. So thank you so much for giving that a positive framing, and seeing that as an opportunity and not just a challenge. And then with regards to the question, just wanting to hear more about that process of you all adapting, what were some of the shortcuts that you felt you could take and they wouldn't compromise let's say the integrity or the fidelity of the process? And what were other parts of the process that you felt like, no, there are no shortcuts. We really just need to, do this as intended to be able to get the full benefit of it.
Thank you. Yeah, during the implementation of the provider behavior change toolkit, let me say during the diagnosis process, when conducted the daily synthesis, after doing, for example, the client's scenarios or the interviews with the clients, and then you also do interviews with health providers or the health officers. For the health officers and the health providers, it's clear that you have to use the synthesis tool. But as for the clients, we use the client scenarios. So at times you'll need to think around, how do I now use this information on the synthesis tool? Of course, we have the point of view, which we use the point of view to be able to synthesize the interviews we have with the clients, as well as the let me say, the facility guided visit. These two tools, we use the point of view to be able to synthesize. Otherwise, you may get confused at this stage, but it's important to know that at some stage, what information you have could not enter into the synthesis tool, the developed synthesis tool, but use the point of view tool. Thank you. I don't know if I've answered your question, but I think that's from the experience I had in rolling this out. Thank you.
Thank you, Kenny. And Barbara, over to you. Anything to add from your examples or your experience?
I think the very first confusion that we got was on using the action planning tool, because I remember we were not in position to do the action planning immediately after we had gathered that information. And the disadvantages that comes up with. So at the end of the day, we noticed that, hey, we hadn't used that tool, and then it took us some other time to go back and sit with the health providers to see how best we can capture the different action plans that actually the action plans were not even asked for at that time when we presented the influencing cards. And I think this was because of the complexity of the tool. We missed out on the action planning. So when we got back home, we're like, hey, we did not have the actions captured. So it had to take us another time to go back And it's not that it was challenging at first, because we did not, it wasn't guaranteed that we are going to meet the same providers that we met at the time we were administering the influencing factors. So I think that was one of the issues and the challenges that we got. Yes.
Thank you, Barbara. And I'd like to remind our guests and our participants here, please feel free to type any responses, comments, thoughts in the chat, or use the Q&A function on the bottom of your Zoom screen to ask any further questions. So we have a question in the chat. In Africa, mainly in Mali, what tools would you recommend to providers, especially in rural health services? So perhaps thinking about those inspiration cards and those action planning ideation processes that you went through. Kenny and Barbara, do you have any suggestions?
I personally have not gotten the question right. I don't know if I should get into the Q&A and learn it first, but could you just help me rewind?
Yes. So what tools would you recommend to providers? So what tools do you think would be effective in facilitating that provider behavior change? Did you come up with any action plans, or were you able to utilize the inspiration cards to create a intervention or a specific example that you have?
Okay, thank you. From the implementation, yes. Through the diagnosis process, we have the synthesis process, and then we have the global synthesis where we summarized all the informations, of course, from the daily synthesis. And then, of course, we move to the next stage where we had the brainstorming together with the clients. And of course, in the brainstorming, it may be very difficult sometimes for providers or the people that you are engaging in ideation sessions to be able to generate that kind of idea without the inspiration cards. The inspiration cards are there just to be able to guide them and give them an idea. And of course, that enables them or enables their thinking to flow as quick as possible. And yes, of course, the influencing factor cards are very good because it gives them that idea of what exactly is required to address a problem that they have stated themselves or they have mentioned during the process. Yes, and I'm looking at the brainstorming session and using the inspiration cards to be able to generate those ideas from the team that you're engaging. Over to you.
Yes, and I think all cards are equally important, because from the flow of if I may say, one card leads to the other. So where possible, I would encourage that we try as much to use as many cards as possible. But and I think that's why I'm failing to pick out what is most important, because like I said, each card leads to the other. If you look at the influencing factors, you might not be in position to do away with the influencing factors. From the influencing factors, you need to capture, the action plans. If you talk about the inspiration cards, so I think, and this goes back to the point I raised at the start, how best can we have all these cards, but in a more simplified manner? Because like I mentioned, each card is equally important and each stage leads to the next stage. Yeah.
Yes, absolutely. So each of these tools, there's not going to be one specific tool or intervention that's going to work across settings. So it's so important to utilize all the different influencing factor cards and inspiration cards and tools within the toolkit to identify what will work in your context. So there isn't a specific answer, whether you're in Mali or Uganda or South Sudan. It's really going to depend on the providers that you're working with directly.
Exactly. And to add to what Allison, Barbara, and Kenny have been saying, these tools, the provider behavior ecosystem map, the provider behavior change toolkit, the provider behavior change monitoring and evaluation brief, these are all these are all tools that were developed with a global lens and are meant to be adapted. So no matter where you are in Mali, you should be able to take these tools and adapt them to your context. And as Barbara was saying, where you're seeing a need to simplify, if things are seeming overly complex, feel free to do so. That won't compromise the integrity of the toolkits. It's really going to be just that tailoring that needs to happen so that it can be most in your team. And the other thing I will say as well regarding the toolkit, also in response to what Barbara said, is I'm so glad to hear that in your experience, you all are recognizing the value of all the different pieces of the tool, and also recognizing the importance of looking at all those different levels of the socio-ecological model to be able to understand the relationship. It might not be possible within the scope of a project to be able to influence health policies, but it's still important to be aware of health policies and the impact that those are then having on the health system, on the health facility, on the providers, so that you can then, in prioritizing the behaviors you want to address, really be able to hone in on those that you can address and have the most impact on. So I make that point about really trying to stretch yourselves and learn about all the different factors across the socio-ecological model to then be able to do more of that prioritization and focus that's going to be necessary. And I also want to bring up here the importance of collaboration and partnership. So especially with the PBC toolkit, it's so intentional, this whole idea of having your core implementation team that includes providers, that includes health facility leadership, that includes community members, that includes other partners and stakeholders, right? Because things that you all end up identifying that your specific project isn't able to address can actually be addressed by other projects. So it's a really great opportunity for people to come together to more comprehensively address all these different factors that we know are influencing provider behavior in a particular community, in a particular state, in a particular region. I know oftentimes we can be so focused on our projects, and I also know that so many of you are doing really great work in partnerships. So let's leverage those partnerships, bring our partners into these using these tools as well, so that we can then demonstrate how we are really combining forces and scaling up impacts.
Yes, well said, Danette. And we do have a comment and question from John D. Actually, I would like to, John D, if you're willing and able to, go ahead and unmute yourself and share your experience in terms of vasectomy programs and ask your question to the panelist.
Yes, thank you very much. I was considering the wonderful provider behavior ecosystem map you shared, and specifically the part showing client experience of the provider as having affecting him in his carrying out some tasks. My experience was with a vasectomy program and services for men, where the health centers and most workers in my country were used to providing services for women. So at the minimum, these providers were very uncomfortable with male services, and even philosophically, some of them were even claiming that such programs were drawing resources away from women, family planning, and reproductive health. So I was wondering if you have examples or experience with similar efforts to encourage providers used to what they were doing to try out and work on new programs.
Allison, I'm happy to jump in. This is one of the areas that I work in, so I'm so excited that you brought it up. I'm going to share a suite of tools that Breakthrough Action developed specifically around engaging men and boys in family planning. And although it's specific to family planning, it can also be adapted to other health areas similar to these provider behavior change tools. And I'll also share in the chat later on when I'm done talking about specific resources that really look at how to sensitize and work with providers around the working with male clients across life stages, across ages. You make an excellent, and I'm going to once again bring in the socio-ecological model of how, in looking at our health policies and advocating with policymakers, we need to look at the health-related policies and how oftentimes those are very gendered. And that is something that we bring up in the provider behavior ecosystem map. When we have gendered policies that are only, and I'm not saying that women and girls should not be prioritized. Those arguments have been made and continue to be made for good reason. What I'm saying is that we know that men also have a role to play when it comes to family planning and sexual reproductive health. And it's important that we're also engaging them in the conversation, not only to address their own health needs and priorities, but also how they can be partnering more equitably with their partners, right, when it comes to this particular health area. So it's really important to do that work of sensitization and training with providers. Oftentimes providers might be interested, but just don't know. And so learning about what their attitudes, values, and beliefs are in engaging men and boys around this area, and also what they don't know. It could very well be that in their they didn't learn, right, about engaging and working with male clients in the same way that they did with female clients. So providing those opportunities for bringing providers together, for sharing about their experiences, what their anxieties might be, what their needs might be, and then developing training or other initiatives to be able to address that is a really good starting point. And also, as couples are coming into the health clinic, right, trying to figure out what is that dynamic going to be when you have the two partners together. Who are you addressing more or less? I don't want to go on too much because it's an important part of this, but I know that we're here for another reason. But just know that I'll be sharing some more resources in the chat that can really speak to male engagement, and also an invitation to join the Male Engagement Task Force, which is a global network of folks who are very much focused on engaging men and boys more and more in health programs and services.
Thank you very much, Danette. I look forward to that chat information.
Kenny or Barbara, do you have any examples? Oh, please go ahead.
Yes, maybe I wanted to share something similar to what the question was about. Back home, we have issues whereby the health providers were not providing certain methods of family planning. And what stood out mainly was IUD and, of course, the tubal ligation. And we found out the reasons why they were not actually providing it was because there was a knowledge gap. Yes, was a knowledge gap. So it had to take us a series of coachings and mentorships to make sure that we bring them on board. So in most of the scenarios, what is it called? The capacity issue sometimes tends to let providers shy away from providing certain services or engaging themselves in different programs. So I think it's an issue also that needs to be looked into. Yeah, thank you.
Yeah, from my side, what I would just say is that since the provider behavior change toolkit is an evidence-based kind of a toolkit that generates for us information on how we can be able to respond from the rollout of the provider behavior change toolkit in one of the locations here in South Sudan, we were able to realize that some of the influencing factors or factors that influence providers to provide family planning services, for example, is related to threats from partners of family planning users, women who use family planning. So as a result, I think Momentum Integrated Health Resilience is currently using some of the tools Breakthrough Action South Sudan initially developed, and one of it being what Danette just mentioned, and which is the male engagement board game, which we are currently rolling it out in these locations to be able to create a sense of, let me say, knowledge to, or try to be able to raise an awareness to the men to understand the importance of family planning. So this is, I think, what I can just be able to respond in relation to what Jody just asked. Thank you.
Thank you, Kenny. Thank you, Barbara. Any follow-up questions to their comments? Perhaps John D, if you have any other questions, or anyone else from our audience here? And feel free to unmute yourself or type your questions in the chat. Yes, John, I see you have your hand raised. Please go.
Yeah, just to confess that I've also been a provider that has fallen into the trap of getting used to what we've been doing so often. 3 decades ago, I was too proud of my willingness to go down to the community and engage with men to promote family planning, not realizing that men are not that open and they are hesitant to engage with me and be seen as being interested in vasectomy. Just a couple of years ago, my younger colleagues and coworkers pushed me to consider social media. And social media with the anonymity provided and the men not being too public when they engage with us, generated much more than I had been used to, where we could only get at most 20 vasectomies in a year because of social media and this new approach that I was not used to. We were generating 200 to 600 vasectomies a year now. So I'm also at fault with being too comfortable with what I was used to.
Yes, I'm so excited that this is what it's about, y'all, right? It's like providers are people too. Thank you so much just for like being vulnerable and sharing that with us and sharing about how you're just, revisiting your own practices and things that you might be doing differently going forward. I think like it's so important that we lean into that and are constantly revisiting and rethinking. And so I applaud you for doing that and how you might also be bringing your fellow providers along. And lastly, just want to speak to your point about social and gender norms and how what you said plays out in so many different places, right? And that's why it's so important that we be engaging with men and boys more and understanding those social and gender norms that impact the extent to which they're interested in accessing health information and services. And also those who might be interested often feel that barrier of not wanting to be perceived differently or negatively by their community. And so there's so many different factors. There's so many things that we need to understand more about boys and men to be able to meet them where they're at and start changing the culture, not just among men and boys, but also among everyone in the community, right? Everyone has a role to play perpetuating social and gender norms that are not helpful or that are harmful. And I think it's so important that we remember that, right? Like even women can perpetuate inequitable gender norms, and it happens a lot. I won't speak about my own experience and my mother treating me differently from my brothers, but I think we all see how that plays out. And so how is it that we are understanding everything that contributes to men and boys not being as engaged across these different health areas, and how then can we support that going forward?
Thank you, Jondi, for sharing that, and Danette as well. And Mamadou, I see your questions in the chat. So panelists, could you share any experiences or examples that you have on working on provider behavior change in insecure areas or areas with limited resources? Do you have any specific examples you can share?
Okay, from my side, what I can just mention is that we are at our initial stages of rolling out the provider behavior change. And of course, our context is that of a limited resource. And we are yet to see how how we're able to move on with these limited resources. For example, most of our projects are donor-driven, and also the government has limited, let me say, kind of support in terms of facilitating the running of the health facilities. Yes, we are yet looking into how this, and we'll be able to understand more when we completely roll it out and are able to, I think, do it in several locations to understand further. Thank you.
I think from my side, what I can say is that, yes, most of us work with limited resources. And what we are doing is to make sure that we tap into the already existing resources. And Danette talked about collaborations and partnerships. I think if we are strategic enough, for example, in identifying the core implementation team, we can scatter it around or across the different people to see how best we can tap into their resources. Because, for example, the project I'm working on, there's no way you're going to get a specific kind of resource to support this PBC. So you have to find means and ways of integrating with the ongoing and running programs or activities. Yes, thank you.
Yes, great points, Barbara and Kenny. We just have a few minutes left here. Time has flown by this past hour, but I would like to open the floor for our panelists to provide any final remarks, maybe give our participants and our audience here a 1-minute speech on why we should all be using these tools.
Yes, I think why we should all be using these tools is that they support us to solve, or before solving, understanding any barriers, any situations at different levels of implementation. There's no single way that we are going to achieve, for example, a family planning uptake if we are only dealing with the providers. We need the entire leadership. We need the human resource. We need the supply chain to make sure that we have the commodities. And these tools will be in position to help us identify the different factors at different levels and go ahead to support in providing solutions to address those different challenges at different levels of implementation. So if everyone could embrace the PBC toolkit, and I think this should also go beyond other family planning programming to cater for any other programs that the different people might be engaged in. Thank you.
Yeah, we really need to use, why we need to use the provider behavior change toolkit is that, providers are humans like us, and they come from the same community where we come from, and these communities have different social and cultural norms that may influence them. And it's important for providers also to learn that they are key in terms of bringing people towards or to the facility to be able to access services by changing their behaviors. So it's important for us to use the provider behavior change toolkit to be able to create behavior change in providers. Thank you.
Well said. Thank you so much to our panelists and to our participants here. You'll see a poll that just popped up on your screen. If you all don't mind taking a few seconds here to fill out this poll. Otherwise, thank you so much for joining our Q&A session, and feel free to reach out to Breakthrough Action with any further questions or comments, and we hope to hear from you soon. Thank you all.